about the cardiovascular physiology, we have multiple variables, and that means they're changing by different factors, due to different factors. So, first of all, we have the stroke volume. The stroke volume is basically the amount of blood that the blood can or have the possibility to pump out into the vascular system. So stroke volume is affected by different variables like the contractility. It's about basically it's the capability of the heart to contract, and also the afterload. And what I say about it is that it's kind of the resistance that the ventricle, for example, should pump against in order to be able to take out the blood or just give out the blood for the vascular system. And the preload is the amount of blood that is already there in the heart, and it's approximated, as I say, by the end-diastolic volume. So it's about how much of a blood is there in the heart at the end of diastole. It's when the heart is relaxing. So for the stroke volume, it increases with the increased contractility. So whenever the heart increases its capability of contracting, just like in anxiety or exercise, then the stroke volume, of course, like the amount of blood coming out of the heart, would increase. And also if there is an increase in the preload, that means, for example, in early pregnancy, that also increases the stroke volume. And there is decrease in the afterload, that means decrease in the resistance that the heart should pump against, which means it's easier for the heart to pump. So basically the heart will pump a higher stroke volume of blood. So this is for memorization, but a failing heart has decreased stroke volume. That's common sense. If we have heart failure, then the heart loses its capability of pushing too much and just putting too much stroke volume outside of the heart. So because it's a failing heart. So that happens in case there is systolic and or diastolic dysfunction. For the contractility, it's contractility, the capability of the heart to contract. So it's proportional directly to the stroke volume. So they both increase with different factors. So one is 2, 3, 4. So for one, it's the catecholamine stimulation via beta 1 receptor. So basically, this is the nervous system activating its beta 1 receptors through the catecholamines. So two mechanisms will take place over here. First, we're going to start with the activated protein kinase leading to phosphorylation, to phospholambine phosphorylation. And then that means the active calcium channel, active calcium ATPase channel leading to increased calcium storage. So what happens here is that after this phosphorylation process, after the activation of protein kinase A, that would lead to increasing the activity or activate the calcium ATPase channel which is responsible for increasing the calcium inside the calcium storage inside the cell, inside the myocytes, inside the muscle cell of the heart. So as we're supposed to know that the calcium is the one that is responsible for contracting the myocyte. So its presence inside the cell, if it's stored there or whatever, then that would increase the contractility, like the activity of the myocytes. So basically the calcium storage should be in the sarcoplasmic reticulum. It's one of the components of every muscle in the body. So that's for mechanism 1 after the catecholamine stimulation via beta 1 receptors. For the mechanism number 2, there is also activated protein kinase A leading to activation of calcium channel phosphorylation. So this would lead to a different kind of phosphorylation. So this is phosphorylation of phospholambane, and while this is phosphorylation of the calcium channel itself. So after the phosphorylation of calcium channel itself, that would increase the calcium entry into the cell. So increasing the calcium entry into the cell by itself will increase the calcium release from the storage. So basically it's just calcium would induce more calcium release. Calcium helps in releasing more calcium from the starch. So that's for the two mechanisms after the nervous system activation, the catecholamine stimulation through the beta 1 receptors. The other mechanism that doesn't necessarily require the nervous system is just by any means increasing the intracellular calcium, anything that would lead to an increase calcium inside the cell, inside the myocyte, whether it's nervous system or not. So number 3 is reducing the extracellular sodium. That would reduce the activity of sodium calcium exchanger. So what we have is we have a channel over here that is supposed to take inside the sodium. This is the outside of the cell of the myocyte, and this is the inside of the myocyte. So this exchanger is supposed to take in sodium from the inside, and supposed to take out the calcium outside of the cell. So this exchanger. So if we have actually just lower sodium outside, like we have very low sodium outside here, that means this exchanger just doesn't go and take what's already low. If it's low, then it's just going to keep it out there. It doesn't make sense if it takes all of it inside the cell, so it cannot. So that means this exchanger is not going to work. If sodium is not going in, that means calcium is not going out, and if calcium is not going out, then it means inside the myocyte the calcium concentration goes up, and we know that calcium is responsible for the contraction or the contractility. Yes. So there's another channel. So what we said about the first channel is there is a pump that is sodium, a potassium pump. This is the outside of the myocyte, and this is the inside of the myocyte. So what under normal conditions, this pump is responsible for taking in potassium and putting out sodium to the outside. So this is how it should work. It should just take the sodium from the inside, put it outside the cell, and then take the potassium from the outside, putting it inside the cell. So if we have a treatment like digoxin over here, so that would basically block this pump. So whenever it blocks this pump, that means sodium is not going outside. So sodium accumulates inside the cell. Now, this is what meant by increased intracellular sodium. So that means the other channel that we talked about, that was sodium calcium exchanger, is just having that's supposed to take in sodium and put out calcium, would already find a lot of sodium inside because of this. So there's already a lot of sodium inside, so there's no need to have more sodium coming in from the outside to the inside. So the calcium by itself is also not going to work, and that would lead to an increased intracellular calcium concentration. So this is the increased intracellular calcium concentration. So these are the effects that would increase the contractility. But for effects for factors that would reduce the contractility and stroke volume, like beta 1 blockade, that would reduce the cyclic AMP, and if there's a heart failure with systolic dysfunction, or if there's metabolic disturbance like acidosis, and if there's hypoxia or hypercapnia, so reduced O2 partial pressure or increased CO2 partial pressure. Non-dihydropyridine calcium channels like verapamil probably. So that's for contractility. For the preload, it is basically approximated by the ventricular and diastolic volume, that is the amount of blood persistence in the heart after the relaxation of ventricles, or after the heart is relaxed, or after the filling phase. That is the end of diastolic volume. So that's the preload, and it depends on the venous tone and the circulating blood volume. It depends about if the veins that are bringing the blood into the heart, if they are vasoconstricted or vasodilated, and also how much blood is there in the whole body. So if we have vasodilators like nitroglycerin, that would reduce the preload, and that so this is a normal vessel, and it has a specific amount of blood in it, ending up in the heart. So if we give vasodilators, then the vessel would go larger, okay, but still it ends up with the heart. So in this case, after vasodilation, after we give vasodilators, the vessel would contain more blood, so it would act kind of a storage to that blood. So that means less blood into the heart, but here more blood into the heart, because it's the same exact amount of blood, but here it would be stored in the vessel rather than the heart. For the afterload, the afterload is approximated by mean arterial pressure. It's about the mean pressure of all arteries and arterioles and the systemic circulation. So if there is an increase in wall tension, according to Laplace law, there will be increase in pressure and increase in afterload. So if they are tense or vasoconstricted, if there is some more tension in the vessel's wall, in the walls of the vessels, so basically the heart would need to pump harder against the increased afterload. So the left ventricle compensates for the increase in afterload by thickening, because it needs to somehow just get that blood out of the heart, so it should pump harder, and that it does so by being undergoing hypertrophy. By being hypertrophied, yes, in order to reduce wall stress. So for the arterial vasodilators, for example, the hydralazine, it reduces the afterload, and the ACE inhibitors and ARBS, they reduce both the preload and afterload, not only one of them, just preload and afterload, both. That's for ACE inhibitors and ARBS. For chronic hypertension, which means increased in the mean arterial pressure, there should be, or we would definitely expect to find, a left ventricular hypertrophy. For the last variable that we have, that is the cardiac oxygen demand, is how much the cardiac muscle itself requiring of a blood. So it needs more, the cardiac muscle or the myocyte would need more oxygen in case it increased its contractility. If it increased the afterload, which means like it needs to pump a little bit harder against the increased afterload. If there is increased heart rate, if there is increase in the diameter of the ventricle, which means the chamber is getting larger, so there is more tension in the wall. So the coronary sinus contains the most deoxygenated blood in the body. We already mentioned that in the previous page. Wall tension follows Laplace law. So the wall tension equals pressure by radius, and wall stress